Every single week, a senior sits in my office, convinced their blood pressure medication is failing them. They sit across from me, clutching a crumpled piece of paper covered in handwritten numbers, completely convinced their heart is getting worse, convinced their blood vessels are failing, convinced that something profoundly serious is going wrong inside their chest. And in almost every single one of those cases, the medication isn't the problem. The problem is that nobody ever sat down and explained what that pill actually does once it leaves the bottle. Nobody explained what it's quietly capable of, how it alters your physiology, and, most importantly, which warning signs mean write this down and mention it at your next checkup, versus which ones mean drop everything and get to an emergency room right now. So let me ask you something completely direct. If you take Amlodipine, Losartan, or Lisinopril every morning with your coffee or your breakfast, do you actually understand what that chemical compound is doing inside your bloodstream today? I don't mean the generic line printed on the yellow pharmacy bottle. I don't mean the single, rushed sentence a well-meaning but exhausted nurse mentioned 2 years ago during a 10-minute visit that was over before your mind even processed the diagnosis. If you paused just now trying to answer that, if you realized you don't actually know the mechanism keeping your cardiovascular system alive, you are not alone. And more importantly, that is not your fault. It is the fault of a broken medical system. Most people are handed a prescription, given a generic warning leaflet printed in microscopic font, and sent home with less actual information than they'd get if they bought a new microwave or a kitchen appliance. My name is Dr. Reeves, and to be completely frank with you, I am done with that. I am done watching patients panic because of a lack of clear communication. Today, I am going to give you everything that 10-minute appointment never had the time to provide. By the end of this video, you will understand exactly what these 3 massive blockbusters of the medical world are doing to your organs, what is perfectly normal, what is an expected side effect, and the handful of critical moments where normal quietly crosses the line into a true medical emergency. Let me start by telling you about Margaret. Margaret is 76 years old, a retired high school English teacher who approaches her health with the exact same meticulous organization she used to grade essays. She has a weekly pill organizer, and she color-coded it by priority. For nearly a decade, Margaret took Lisinopril. It worked well, her body tolerated it, and her blood pressure stayed in a relatively safe zone. But as time marched on, her blood vessels naturally stiffened, a normal part of vascular aging, and her numbers started creeping back up into the 150s over 90. At her next routine checkup, her doctor saw the numbers and added a low dose of amlodipine on top of her daily lisinopril. Margaret did exactly what most people do when they are handed a second blood pressure pill. She assumed it was just more of the same. She thought her doctor was just giving her a stronger dose of the same basic medicine. Nobody in that busy clinic took the 60 seconds required to correct that assumption. 3 weeks later, Margaret woke up and looked down at her feet. Her ankles had swollen to twice their normal size. The skin was tight, shiny, and indented deeply when she pressed her thumb against it. She couldn't get her loafers on. Because nobody had explained the unique nature of amlodipine, Margaret made a terrifying, logical leap in her mind. Swollen legs mean fluid retention. Fluid retention means congestive heart failure. My heart is giving out. She spent a miserable, frightened weekend sitting in her armchair, looking at her swollen ankles, utterly convinced her independence was ending and her heart was failing. All before she ever picked up the phone to call my office. That core assumption, the belief that all blood pressure medications are basically the same drug with different names, is one of the most common and most dangerous misunderstandings I see in modern medicine. So let's correct it permanently, right now. The three drugs are not the same drug. Yes, all three of these medications share a common final goal. They lower the pressure inside your arterial tree. But that is where the similarities end completely. They achieve this goal through radically different chemical pathways, targeting entirely different organ systems and receptors. To understand how they differ, think of your circulatory system like the plumbing in an old house. If the pressure in the pipes is too high, you can lower it in a few different ways. You can physically widen the pipes. You can turn down the main water valve from the city, or you can drain some of the total volume of water out of the system. Amlodipine is what we call a calcium channel blocker. Inside the walls of your arteries, there are tiny, smooth muscle cells. For those muscle cells to contract and squeeze the artery tight, they need calcium ions to flood into them through microscopic channels. Amlodipine acts like a physical plug in those channels. It blocks the calcium from entering. Without calcium, those smooth muscle cells cannot contract. They are forced to relax and dilate. When the pipes widen, the pressure drops instantly. Lisinopril belongs to a class called ACE inhibitors. This drug doesn't work directly on the muscle channels. It works on your hormone system, specifically targeting an enzyme produced largely in your lungs. This enzyme is responsible for creating a powerful hormone called angiotensin II. Angiotensin II is the body's master constrictor. It clamps down on blood vessels like a vice grip. Lisinopril stops that enzyme from ever manufacturing the hormone in the first place. It cuts off the chemical signal before it can ever be sent. Losartan is an ARB, or angiotensin receptor blocker. It operates in the exact same biological neighborhood as lisinopril, but with a clever twist. Losartan allows your body to go ahead and make the angiotensin II hormone, but it rushes ahead and sits inside the docking ports, the receptors, on your blood vessels. Think of it like putting chewing gum inside a door lock. The key is there, but it can't fit into the lock anymore. Because the hormone can't dock, it can't cause the vessel to squeeze. Three completely different mechanisms, three entirely distinct side effect profiles. Once you understand exactly which category your specific medication falls into, you stop interpreting every single new sensation in your body through a lens of fear, and you start recognizing what is a predictable, manageable response to the chemistry you are putting into your body. Let's zero in on the phenomenon that terrified Margaret: the lower extremity swelling, known medically as peripheral edema. This is hands down one of the most frequent reasons patients abandon amlodipine, often to their own detriment. When you take amlodipine, remember that its primary job is to relax smooth muscle. It does this beautifully in your arteries, the vessels carrying oxygen-rich blood down from your heart to your tissues. However, amlodipine does not have nearly the same relaxing effect on your veins, the vessels responsible for fighting gravity and pushing that blood all the way back up from your feet to your chest. This creates a structural imbalance in your lower legs. Because the inflow pipes are wide open, a large volume of blood rushes down into the tiny capillaries in your ankles and feet. But because the outflow pipes haven't widened proportionally, blood pools in those tiny vessels. The pressure inside those microscopic capillaries builds up until clear fluid is literally squeezed out through the vessel walls and into the surrounding tissues of your ankles, shins, and feet. Let me repeat this clearly so it sinks in. This is a mechanical fluid shift. It is not a sign that your heart muscle is failing. It is not a sign that your kidneys are shutting down. It is a highly predictable, localized side effect of arterial dilation. The true danger of this swelling isn't the fluid itself. It's how people react to it when they are left in the dark. Every single month, I catch patients who quietly stop taking their amlodipine because their shoes felt tight. They didn't tell their doctor because they were embarrassed or figured the drug was poisoning them. Meanwhile, without that chemical block, Their smooth muscles clamp back down, and their blood pressure quietly surges back up into high-risk territory without a single outward symptom. Other patients make the mistake of cutting back drastically on their daily water intake, operating under the false assumption that if they stop drinking fluid, their legs will dry out. This is exactly the wrong move. Dehydrating yourself makes your blood more viscous, strains your kidneys, and actually triggers your body to hold on to fluid even harder. The correct move is simple. You must communicate with your prescriber. If you develop ankle swelling on amlodipine, you don't have to just live with it or suffer in silence. There is a whole menu of clinical adjustments available. We can lower the dose from 10 milligrams to 5 milligrams, which often eliminates the swelling while retaining much of the benefit. We can shift the timing of the dose to right before bed, so the peak fluid shift happens while your legs are elevated horizontally in sleep, rather than standing vertically all day. Or, we can combine it with an ACE inhibitor or an ARB, which naturally dilates the veins and relieves that capillary pressure, pulling the fluid right back into circulation. But none of these elegant clinical fixes can happen if you keep the symptom a secret. If amlodipine owns the trophy for causing swelling, lisinopril indisputably owns the trophy for causing the most annoying, persistent, and misunderstood respiratory side effect in primary care, the dry, hacking ACE inhibitor cough. This cough is unique. It is not a productive cough. You aren't bringing up phlegm or mucus. It feels like a constant, localized tickle or scratch right at the back of your throat that never goes away, no matter how many gallons of water you drink. It is completely unresponsive to over-the-counter cough syrups, throat lozenges, or antihistamines. And to make matters worse, it typically intensifies the moment your head hits the pillow at night, disrupting your sleep and leaving you exhausted the next morning. The trickiest part about this cough, the part that completely derails patients and doctors alike, is its timeline. It does not always start the morning after you take your first pill. Some people develop it within 48 hours, but many others don't develop it until 4, 5, or even 6 months of daily compliance. By that point, the medication has become a background habit, and patients rarely connect the dots. Take Frank, a 68-year-old retired heavy machinery mechanic who came into my clinic last year. Frank had been suffering from a brutal, disruptive dry cough for 9 solid months. He was exhausted, cranky, and genuinely terrified. Because he used to work around asbestos and diesel fumes, his mind immediately went to the absolute worst-case scenario, lung cancer. He had already been to an urgent care clinic twice. The first doctor told him it was post-nasal drip from seasonal allergies and put him on a steroid nasal spray. It did nothing. The second doctor told him it was a lingering viral bronchitis and gave him an inhaler. It did nothing. He had spent close to $100 on over-the-counter suppressants. When he finally sat down in my examination room, I looked at his chart and saw he had been started on lisinopril about a year prior. I asked him one precise question. "Frank, map this out for me. Exactly when did this cough start relative to when you started taking that new blood pressure pill?" Frank stared at me, his jaw dropping slightly as he did the mental math. "I started the pill in November, and the tickle started right around Easter," he muttered. He had never made the connection because nobody had ever told him that a heart pill could affect his lungs half a year later. Here is the simple chemistry of why Frank suffered for 9 months. Remember that lisinopril blocks an enzyme in your lungs. That enzyme doesn't just make blood pressure hormones. It also has a second job. It breaks down a natural inflammatory chemical in your respiratory tract called bradykinin. When lisinopril deactivates the enzyme, bradykinin levels slowly build up inside your lung tissue. In some people, that accumulation eventually irritates the local nerve endings, triggering a chronic neurological cough reflex. We switched Frank from lisinopril to Losartan that very afternoon. Because losartan blocks the receptor rather than the enzyme, it leaves bradykinin completely alone. Within 12 days, Frank's 9-month-old cough vanished entirely. He slept through the night for the first time in an entire year. This is exactly the gap I want to close. Not because any one doctor failed Frank, but because a system that gives a doctor 7 minutes per patient was never built to catch something like this. You catching it yourself by knowing what to watch for is often faster than waiting for the system to catch it for you. But as annoying as Frank's cough was, it was completely harmless. It was a nuisance. However, lisinopril can occasionally cause a separate reaction on the exact opposite end of the severity spectrum. And this is the absolute line I need you to commit to memory today. If you are taking lisinopril or any ACE inhibitor, and you ever notice a sudden, inexplicable swelling of your lips, your tongue, your eyelids, your face, or the inside of your throat, that is not a routine side effect to monitor. That is a life-threatening medical emergency known as angioedema. Angioedema happens when that same chemical buildup causes a massive, localized surge of fluid to flood the deep tissues of your face and upper airway. It can cause your tongue to swell to twice its size, completely blocking your air passages within a matter of minutes. It can restrict your ability to swallow or take a breath. If you ever experience this, you do not sit on the couch and wait for it to pass. You do not take an antihistamine or an allergy pill to see if it improves. You do not drive yourself to a clinic. You call emergency services immediately. A cough is a reason for a phone call to my office on Monday morning. Face and throat swelling is a reason for a siren. Keep that distinction permanently locked in your mind. Now let's talk about losartan. Losartan is often the drug we switch patients to when they can't handle the lisinopril cough. And for the most part, it is exceptionally well tolerated. But it carries a hidden trap that catches well-meaning, health-conscious seniors completely off guard. To understand this trap, we have to look at how losartan interacts with your kidneys. By blocking angiotensin receptors, losartan alters how your kidneys filter electrolytes. Specifically, it signals your kidneys to excrete sodium into your urine while actively reabsorbing and retaining potassium. For most people, this slight rise in potassium isn't an issue. Your body adjusts. But the danger multiplies when a patient decides to take their cardiovascular health seriously by making a common dietary switch at the grocery store. Imagine you are diagnosed with high blood pressure. You watch medical videos, you read health articles, and you know you need to slash your sodium intake. You go down the baking and spice aisle, and you find a product labeled as a heart-healthy salt substitute, or low-sodium salt. You look at the back. It promises 100% of the flavor of real salt with 0% of the sodium. It sounds like a miracle cure. What the packaging doesn't explain clearly is that to get rid of the sodium while keeping that salty taste, manufacturers replace sodium chloride with potassium chloride. So, think about the dangerous equation you've just created. You are taking a drug like losartan or lisinopril that forces your kidneys to hold on to potassium, and at the exact same time, you are shaking a salt substitute onto your eggs, your soup, and your vegetables, loading massive artificial doses of potassium straight into your digestive tract. This can lead to a dangerous clinical state called hyperkalemia, or excessive blood potassium levels. The terrifying thing about high potassium is that it is a silent predator. It doesn't announce itself with loud, obvious symptoms. When it does cause symptoms, they are frustratingly vague. An unusual, heavy feeling of fatigue in your muscles, sudden, unexplained cramping in your calves or thighs, or a brief, strange fluttering or skipped beat sensation in your chest. But if potassium levels climb high enough, they begin to directly disrupt the electrical conduction system of your heart muscle. It can cause your heartbeat to slow down to dangerous levels, or trigger lethal cardiac arrhythmias. If you or someone you love is taking Losartan or Lisinopril, look inside your spice cabinet today. If you are using a potassium-based salt substitute, stop using it immediately until you have a direct conversation with your primary care provider. Furthermore, be cautious with heavy daily consumption of other massive potassium sources, like pure coconut water, raw vegetable juices, or eating multiple bananas a day while on these specific medications. Moderation and regular blood testing are your shields here. This next section is something that is almost never covered in a standard discussion, yet it drives thousands of preventable hospital admissions every single year. We need to talk about what happens to these three medications when you experience a common, everyday illness. Let's say you catch a rough stomach virus. For 48 hours, you are dealing with severe vomiting, relentless diarrhea, or a high fever with heavy sweating. You can't keep fluids down, and you certainly can't manage a full meal. You are, by definition, becoming rapidly dehydrated. Under normal circumstances, when your body detects dehydration, your kidneys rely on that hormone system, the renin-angiotensin-aldosterone system, to clamp down your blood vessels and maintain a safe blood pressure to your vital organs. It's your body's built-in survival mechanism to keep your blood pressure from bottoming out when you are low on water. But if you are faithfully swallowing your lisinopril or losartan every single morning during that illness, you have chemically disabled your body's survival mechanism. The medication prevents the blood vessels from constricting, and it prevents the kidneys from conserving fluid. Combined with severe dehydration, your blood pressure can drop like a stone. Suddenly, the exact same dose of medicine that is perfectly calibrated to keep you safe when you are healthy becomes far too powerful. The pressure dropping too low means blood flow to your kidneys drops off a cliff, which can cause a rapid, dangerous condition called acute kidney injury. At your very next routine checkup, I want you to ask your provider this exact word-for-word question. Doctor, what are my sick day rules for my blood pressure medication? If I get a severe stomach bug and can't keep liquids down for more than a day, should I temporarily hold my dose? For many patients on ACE inhibitors, or ARBs, doctors will advise briefly pausing the medication for 24 to 48 hours until fluid volume is restored and vomiting stops. But do not make this decision on your own guesswork. Ask your provider ahead of time so you have a game plan ready before the illness hits. We live in a culture where over-the-counter medications are viewed as fundamentally harmless. Because you don't need a doctor's signature to buy them, and because they sit on open shelves next to cough drops and vitamins, we assume they carry zero systemic risk. This is a massive, occasionally catastrophic illusion. The specific items I am talking about are NSAIDs, or non-steroidal anti-inflammatory drugs. This includes common medications like ibuprofen and naproxen. Let's say you have a flare-up of arthritis in your knee, or you spend a weekend working in the garden and throw your lower back out. It is completely natural to walk into your local drugstore, grab a bottle of ibuprofen, and start taking 2 or 3 pills a day to manage the pain. What you cannot see is the quiet war that ibuprofen is launching against your blood pressure medication inside your kidneys. Your kidneys filter your entire blood volume every few minutes through tiny clusters of vessels. To do this safely, they balance the pressure of blood entering the kidney versus blood leaving the kidney. NSAIDs block a compound called prostaglandins, which naturally dilates the entry pipes to the kidney. When you block that compound, the entry pipes clamp shut, drastically reducing blood flow into the kidney's filtration system. If you are already taking lisinopril or losartan, which dilates the exit pipes, adding an NSAID means blood can't get in, and what little blood gets in drains out too fast. If you also happen to take a diuretic, a water pill, you create what we call in medicine the triple whammy. This trio can cause an abrupt, silent shutdown of kidney function, while simultaneously causing your systemic blood pressure to spike by several points, because the NSAID causes your body to retain fluid. Your kidneys do not care if a medicine came from a fancy prescription bottle or an over-the-counter plastic tub. They respond strictly to the chemistry. If you are taking Amlodipine, Lisinopril, or Losartan regularly, you need to treat NSAIDs with extreme caution. For minor aches and pains, acetaminophen is typically a much safer choice for your kidneys, provided your liver is healthy. For chronic pain, you must have an integrated discussion with your doctor rather than self-medicating from the pharmacy aisle. There is a specific symptom that I have to actively drag out of my older patients during exams because they almost never volunteer it on their own. Orthostatic dizziness. It's that brief, swimming sensation in your head, that slight wobble or blurring of vision that happens when you rise quickly from a deep sofa or stand up fast after lying down in bed. When I ask my patients about it, they usually shrug it off. They say, "Oh, that's just old age, Dr. Reeves. I just have to catch my breath for a second. It's nothing." It is absolutely not nothing. As we age, our blood vessels naturally become less elastic. When you stand up, gravity instantly tries to pull a large volume of your blood down into your legs and belly. To prevent your brain from being starved of oxygen, tiny pressure sensors in your neck are supposed to instantly fire a signal telling your blood vessels to clamp down and squeeze that blood back up to your head. When you take powerful blood pressure medications, you are intentionally blunting that clamping response to keep your overall pressure low. As a result, when you stand up fast, it takes your body significantly longer to adjust the pressure. Your brain experiences a brief, temporary drop in blood flow, causing that wave of lightheadedness. Here is why this matters deeply. In older adults, a 2-second wave of dizziness is more than an inconvenience. It is a leading cause of catastrophic falls. A sudden stumble leads to a hip fracture. A hip fracture leads to a major surgery, a lengthy hospital stay, a loss of mobility, and a profound derailment of your independent lifestyle. If your dizziness is mild and infrequent, the behavioral fix is simple. You must learn to transition slowly. First, when waking up, do not jump straight out of bed. Second, sit flat on the edge of the mattress for 30 full seconds, letting your feet dangle. Third, flex your calf muscles a few times to pump blood manually back up to your torso. Fourth, stand up slowly while holding onto a stable piece of furniture. But if this dizziness is happening every single day, if it makes you feel like the room is actively spinning, or if you ever feel like you are actually on the verge of fainting, that is not a "just get up slower" problem. That is a critical signal that your dose may be too high, your body is profoundly dehydrated, or your combination of medications needs an immediate clinical overhaul. Do not hide this symptom out of fear. Report it to preserve your safety and independence. Since we are closing the information gap today, we have to look at the tool you use to track your health. Your home blood pressure monitor. Almost every week, a patient calls my clinic in a state of absolute panic because their home monitor read a high number, say 175/95. They are convinced they are on the verge of a medical crisis, and their anxiety causes their heart to race, which pushes the number even higher on the next check. When I have them bring that exact same home monitor into my clinic and watch them duplicate how they take their reading, I find that in nearly 90% of cases, the scary number wasn't caused by a failing drug. It was caused by improper technique. Taking an accurate blood pressure reading is a precise clinical procedure. If you do it incorrectly, you can easily inflate your numbers by 10 to 30 points. Here are the 5 absolute rules of home tracking that you must implement tomorrow morning. Rule number 1, the empty bladder. Always go to the bathroom before taking your reading. A full bladder compresses internal blood vessels and triggers a systemic stress response that can falsely raise your reading by 10 to 15 points. Rule number 2. The uncrossed legs. Sit with both feet completely flat on the floor. Crossing your legs at the knees compresses large veins in your lower extremities, artificially elevating your reading by 2 to 8 points. Rule number 3. The supported arm. Do not let your arm hang down by your side or hold it up in the air using your muscles. Your arm must rest comfortably on a table or armrest so that the blood pressure cuff is at the exact level of your heart. Rule number 4. The silent rest. Do not sit down and immediately press the start button. Sit quietly in a supportive chair for 5 full minutes before starting the machine. No talking, no checking emails, no texting, and no watching the news. Let your nervous system settle. Rule number 5. The cuff fit. The cuff must wrap directly around bare skin, not over a thick sweater or a bunched-up shirt sleeve. Bunching up a sleeve creates a tourniquet effect, restricting blood flow and giving you an entirely false reading. I want to close today by giving you a fundamental shift in how you think about your cardiovascular health. Your blood pressure is not a static, carved-in-stone number like your height. It is a highly dynamic, living metric that fluctuates wildly every single hour of the day. It moves in response to your sleep quality, your stress levels, your caffeine intake, how recently you ate, and even the ambient temperature of the room you are sitting in. One single high reading on a stressful Tuesday night does not mean your medication has suddenly failed you. One single low reading on a hot, relaxing afternoon does not mean your drug is suddenly too strong. What matters in medicine is the pattern over time, measured consistently under identical conditions. Stop treating your monitor like a daily test that you are failing or passing. Treat it like a weather station. Track your numbers calmly twice a day for a week. Write them down in a simple paper log or an app, and bring that aggregate data to your doctor. Let patterns guide the conversation, not panic over a single, isolated reading. These 3 medications, Amlodipine, Lisinopril, and Losartan, are marvels of modern medical science that have saved millions of lives from strokes and heart attacks. But they are tools, and a tool is only as safe and effective as the education of the person using it. They require steady, predictable, daily presence in your system, not extra doses taken reactively when you are scared, and absolutely not skipped doses because you feel fine on a particular morning. You now have the education that the modern 7-minute appointment simply didn't have the time to give you. Use it, advocate for yourself, and stay safe.